Welcome back to the deep dive. If you're working in an NHS emergency department, you know the pressure. I mean, every single shift feels like this high-stakes exam.
Mm,
And keeping patients safe, well, that's just the baseline, isn't it? The real challenge for trainees is that jump from being a pure clinician to becoming a leader and educator.
precisely. And that's exactly what we're focusing on in this deep dive. We're tackling Specialty Learning Outcome 9, or SLO 9, support, supervise, and educate.
Right.
And this isn't just, another box to tick for your ARCP. This is the core skill set that really defines effective senior practice in emergency medicine.
Our mission today is to cut through some of that, well, that bureaucratic fog. We've gone through the RCEM guidance to build a really practical roadmap for you.
Mm-hmm.
We want you to stop seeing SLO 9 as just a paperwork burden and start seeing it as the point where you become responsible for your whole team, their safety, their education, their well-being.
The goal is crystal clear. You have to demonstrate competence in delegating safely, giving structured feedback, facilitating learning and all that chaos. And this is critical, supporting the psychological safety of your team.
And we're going to show you how to get the evidence.
Exactly. How to collect it efficiently.
Okay, let's unpack this then. We should start with the basic structure. SLO 9 is built on 3 pillars, and they are, I think, intentionally interconnected.
That's right. The first pillar is support. And this is often the most neglected one, but it's absolutely vital for a sustainable ED.
This is the pastoral side of things.
It is. It's focused on team well-being, on psychological safety. And the core task is about leading structured debriefs after those big critical incidents. A major trauma, a cardiac arrest, a really difficult PACE resus.
But how do you stop that from just becoming a quick chat at the nurse's station? I mean, in the middle of a crazy shift.
Structure's everything. You need to know these frameworks, things like STOP5 or the talk model. The STOP5 framework, for instance, it's just a simple cognitive aid, STOP. Take 5 minutes right after the event. It helps prevent that sort of clinical amnesia and make sure you address the human factors, not just the medicine.
And talk.
Talk is another great one. Team communication. Ask what went well, listen, and key learning. It's a powerful way to make sure everyone's voice is heard. And support, it also means spotting burnout and proactively mentoring colleagues who are struggling.
Right. Okay, so moving to the second pillar, which is supervise. For me, this is where the rubber really meets the road on, patient safety and leadership.
It absolutely is. The core task here is maintaining patient safety while, and this is the tricky bit, simultaneously fostering junior development.
So effective delegation.
Exactly. Effective delegation. It means matching the task's complexity to the practitioner's capability. You just shouldn't be giving a complex shoulder reduction to an F2 if you've not seen them do it safely before.
And what are the key actions we need to be evidencing here?
Running the board, that's a huge part of it. Managing the departmental flow, making those key priority calls. Also, critical remote reviews. So checking ECGs or x-rays that a junior has signed off before a patient goes home, or just quickly reviewing the notes for a patient an ENP or ACP has seen. You are the safety net. You have to document using that net.
Got it. And that brings us to the third pillar, educate. This is the most visible one, I suppose. The one people think of as teaching.
Correct. Teaching and training. The core task is facilitating learning, both in, formal settings, but also, and I think this is more important, that informal shop floor teaching.
The teachable mode.
That's the one. It's gold. And if you're in higher specialty training, so HST, this pillar also means you have to be completing workplace-based assessments or WPBAs for others. It shows you can assess competence in your team.
Okay, this is where we need to get tactical.
Yeah.
What specific evidence do you need at different stages? Let's start with the ACCS or the intermediate and core trainees.
Right. For those in ACCS, the early years, the focus is on developing your basic teaching and supervision skills. You might be supervising medical students or maybe EMPs.
So what capabilities are they looking for?
It's about delivering effective teaching sessions, providing structured feedback, often on, simple technical skills, cannulation, phlebotomy, that sort of thing.
And how do they prove it? What's the minimum evidence they need?
You need at least one teaching observation, a TO2. That's a formal assessment of your teaching. You also need a dedicated reflection on a time you gave structured feedback. By the end of core training, you have to show you can give that feedback on simple skills.
And then it steps up for intermediate.
It steps up. By the end of intermediate, they want to see a solid understanding of non-technical skills, of human factors. You need documented debriefing experience from SIM. And critically, you have to be ready to safely supervise the F2s and other junior trainees across the department.
That makes sense.
Yeah.
Building competence step by step. So now let's jump up to HST level. The registrars, the ST4 pluses. The expectations here,
Yeah.
they shift dramatically, don't they?
The shift is profound. For HST, you are expected to be able to run the department. That means managing the whole clinical team, controlling flow, supervising the full range of practitioners, F2s, ACCS trainees, ACPs.
So the evidence needs to be much more comprehensive.
Much more. You need robust evidence for SLO9. You need an ACAT, that's an assessment of clinical or administrative teamwork that focuses specifically on your leadership and flow management, not just a single complex case.
And what about the other acronyms?
You need a minimum of 2 formal TO2s. You also need to evidence ESLE's extended supervised learning events. This is where you might be supervising a difficult procedure or leading a complex resus, showing really high-level supervision. Plus, you need documented proof you contribute to the departmental teaching rota.
And what's the end goal? By the time you CCT?
By CCT, you must be an independent practitioner and educator. So, confidence delivering feedback in high-stakes environments, like ALS or ATLS courses. You have to be able to give detailed, constructive feedback on non-technical skills, things like situation awareness or decision-making. And you should be teaching on complex topics yourself: management, leadership, system improvement.
That is a huge amount to get into a portfolio. And we all know finding time for formal teaching in the ED is... It's tough.
It is.
So this is where we need the portfolio hack. How do you integrate evidence collection into your daily shift?
Exactly. This is the key. Let's start with the shop floor ACCAT. So many trainees think an AC has to be on a specific patient. It doesn't.
Okay.
For SLO9, ask a consultant to observe you running majors or resus for 2 hours.
Wait, so you're shifting the focus from what was the clinical outcome to how did I manage the people and the chaos? How does a consultant even document that?
They assess your non-technical skills. Did you use your team well? How did you delegate? Did you spot an F2 struggling and intervene? Did you manage conflicting demands? You have to tag this ASTAT as supervision and management of complexity. It turns 2 hours of normal work into high-value evidence.
I love that. It makes leadership a practical skill, not a theory. What about teaching? We need good TO2s, but we don't have an hour.
This is the sniper TO2. It's targeted, high-value shop floor teaching. Use a short clinical interaction. Teaching a foundation doctor a nerve block or an SHO how to interpret a really tricky blood gas.
That's maybe a 10-minute thing, Max. How do you formalize it?
You have to be intentional. Before you start, you grab a senior nurse or another registrar or a consultant and say, "Can you watch this for 10 minutes?" They complete the TO2 right there, focusing on your clarity, your feedback. The guidance really values this kind of teaching because it proves you can educate under pressure.
Brilliant. Okay, final hack. Feedback reflections. Giving difficult feedback. That's hard. When a junior's missed something or is always late, it's tough to reflect on.
But it's critical for that HST level. Focus the reflection on a time you had to give that difficult feedback. And the key is to reference the framework you used. Did you use Pendleton's rules?
The classic, what went well, what could be different?
That's the one. Or maybe you used a LOBA agenda-led outcome-based analysis where you let the learner set the agenda first.
By naming the tool, you're showing you're thinking about your teaching style. It's not just an anecdote.
Exactly. And then you explain how they reacted, how you adjusted your language, what you do differently next time. That's the depth they're looking for.
Right. So if you want to go beyond just competent, if you really want to impress the ARACP panel, you need to show educational leadership. What are the strategies for excellence?
First strategy is to close the loop on your teaching. Don't just deliver a session. Collect the feedback forms, summarize the feedback, reflect on what you'll change, and then upload the entire bundle as one piece of evidence. That shows a real commitment to quality improvement.
That's a powerful way to show engagement. What about the rest of the team? It's not just doctors.
Strategy 2, multi-professional education. Organize a sim session that involves the whole ED team. Nurses, HCAs, paramedics, even porters. Then evidence how you facilitated a debrief where you deliberately flatten the hierarchy. That shows inclusive, systems-aware leadership.
And strategy 3 is about the trauma response.
Become the hot debrief champion. Be the one who proactively initiates a structured debrief with talk after every major trauma or arrest. Then, write a detailed reflection focusing on the team management and psychological support, not just the clinical side.
And the fourth strategy is about leaving something behind.
Yes. Create cognitive resources. Don't just consume guidelines. Create one. A laminated poster, a one-page guide for the department, maybe a flowchart for setting up the NIB machine. It shows you're contributing to the safety of the whole department long after you're gone.
Now, let's talk about the pitfalls, the common mistakes that trainees fall into with SLO9.
The first is what I call the imposter supervisor. This is when you fail to intervene when a junior is struggling because you don't feel senior enough or you doubt yourself. That hesitation can risk patient safety.
And the fix.
The fix is to reflect specifically on graded assertiveness. How do you escalate your concern professionally without shaming the junior?
That psychological barrier is a huge one for new registrars. What's the second pitfall?
The dump delegate. This is just assigning tasks to offload your work with no explanation, no safety net, no learning point. It's efficient, but it's terrible supervision.
So what's the fix for that?
The fix is to use the what-if questioning technique before they go off to do the task. Ask them, what if the patient's blood pressure drops? Or what if you can't get the line in? It forces them to pre-think, and it turns delegation into a proper learning encounter.
And the last pitfall must relate to the chaos of the ED itself.
Ignoring the environment. Trying to force a teaching moment when the department is on red alert and patient safety is at risk. You have to evidence the maturity to prioritize service over teaching when it's necessary.
So canceling a teaching session can actually be good evidence.
It can show strong, mature leadership, which is exactly what SLO9 demands.
This has been incredibly specific. We've thrown a lot of educational jargon around, though. Let's do a quick, rapid-fire summary of the essential frameworks people need to know.
Okay. For feedback, you must know Pendleton's rules. Or, for more specific feedback, set go. What did you see? Elicit your thoughts, the goal, and your offer of help.
And for procedural teaching, a massive part of shop floor work.
For procedures, you need to know Peyton's four-step approach. It's perfect for the bedside. 1. Demonstration. 2. Deconstruction, where you explain it. 3. Comprehension, where they explain it. And 4. Execution, where they do it.
And finally, the context of supervision itself.
Understand Kennedy's framework. It helps you distinguish between broad clinical oversight, your responsibility for a whole group of patients, and focused clinical supervision, which is that specific one-to-one interaction to help a trainee develop. Knowing the difference shows real educational maturity.
So what does this all boil down to for your ARCP? The sources are clear that these SLOs are all interrelated. SLO9 doesn't live in a vacuum. Your communication skills from SLO7 feed directly into how well you debrief or delegate.
And your evidence collection has to be diverse. MCRs, MSFs, TOs, stats, leadership courses, and I think most importantly, really detailed reflections on those challenging encounters.
Ultimately, the assessment of SLO9 is a holistic judgment from your educational supervisor and the ARCP panel. So just remember that checklist. ACCS, 1 TO2 minimum. HST, 2 or more. And your role has to shift from being a debrief participant to a documented debrief leader.
And here's the final thought I want to leave you with. SLO9 is not just about paperwork or getting better at lectures. It's fundamentally about ensuring the sustainability of the workforce. By becoming a truly effective supervisor, educator, and supporter, you're not just helping other people's careers. You are actively making your own future shifts safer, more efficient, and actually more enjoyable. And that, in the long run, is the ultimate goal of educational leadership in a specialty like ours.
Thank you for joining this deep dive. Now go play this knowledge and lead from the front.